Hello, maybe scholars. I hope everyone is doing well or as well as can be. Now, there's been a lot going on in the world, but I do hope that you all are continuing to progress in your respective careers and in your research projects. I am one of the three presenters that's going to be talking about designing interventions. Um, just as a reminder, I'm Dr. Stephanie Fitzpatrick. I am a senior investigator at the Kaiser Permanente Center for Health Research in Portland, Oregon. I'm also a licensed clinical health psychologist. My research area is in developing and implementing behavioral interventions for obesity and chronic disease management in clinical practice. So, what I'm going to be talking about is a little bit more on the behavioral side, but I'll try to make it as general as possible that I know that not everyone necessarily does behavioral interventions, but that's where my expertise is. So, I'm going to share my screen, share my slides here. And okay. So I'm particularly kind of later on in my presentation going to be talking about designing hybrid effectiveness implementation, multi-level intervention, and it's kind of a mouthful, but that's kind of where my work has been going in terms of really implementing evidence-based interventions in the real world, and how do we do that? How do we do that in a sustainable and scalable way? But before I get into that particular topic, I want to first just do just kind of a brief review of the readings that I recommended for you all to read prior to when we're going to get together, I believe, on October 27th. And then I'm just going to go briefly over some intervention design basics, really some questions to ask yourself as you're designing your intervention. And then I will then share kind of as a case example design of one of our clinical trials, DECIPHER Northwest, which is a multi-level intervention to improve hypertension management among patients of color and low-income patients. So one of the readings that I recommended was the paper about the orbit model, which really kind of using the kind of the series of tests that happens in the drug world, applying that to behavioral interventions. And one of the main reasons why I recommended this reading is that whether we're talking about behavioral interventions or different types of interventions, intervention development is a iterative process. You are always trying to refine and optimize your intervention over time, especially as you go through these different phases of testing your intervention. And so, certainly starting with that significant clinical question or that significant clinical problem, that really guides you in terms of thinking about what the intervention components should be and what are the appropriate primary, secondary, intermediate outcomes. But as you go through the process, in this case here that shows in this figure, this phase one design in terms of defining the intervention and refining it, and then get into this more kind of proof of concept of does it work, and then pilot testing it. Along the way, you should be really kind of learning about, is your intervention going to be appropriate? And is it going to be effective? And then if not, and if there's pieces or components that are missing, learning along the way how to refine that. And then the last piece that I just want to emphasize from this article is that there is a lot to learn from basic science. In this case, again, they talk about basic behavioral and social sciences research. That, often from that basic science, we learn about the main drivers, in this case, drivers of behavior change. And those drivers are your treatment targets. And so working backwards, thinking about what the treatment targets are, what are the intervention components that are going to alter or change those treatment targets in the way in the direction that you want that to happen. And also in the article, it points out that even when you get into this efficacy phase, this phase three, refinement of the intervention is still possible because you can learn a lot in the efficacy phase in terms of one, whether or not your intervention is better than whatever the comparison is, which I'll talk about in a couple of slides. But also how realistic is it that the intervention is going to be implemented when you're thinking about trying to move into the phase four, the effectiveness phase. I also just wanted to point out two types of kind of intervention design methodologies that have been around for a while now, and you all might be familiar with these: the sequential multiple assignment randomized trial, or SMART design, and the multi-phase optimization treatment strategy, or MOST design. And I wanted to point these out because these are methodologies that really kind of dig into refinement of the intervention. And so perhaps right before you get to the phase three, the efficacy phase, this is where the SMART and the MOST usually will show up. In the case of the SMART is really almost about kind of developing an adaptive intervention. We know certainly in the clinical world, in the clinical practice, there is not one size that fits all in terms of an intervention, right? You have to tailor the interventions and might go in a kind of a series of steps. If we think about blood pressure management, for one, usually the first step is lifestyle change, behavioral lifestyle change. So eating healthier, engaging in physical activity. If that's not enough, then there might be a medication that's added. If that's not enough, then there's a second or a third medication that's added. So it's kind of like this nice iterative kind of steps that happen over time. And what the SMART does is really help you to think about what are those various steps in this adaptive intervention that need to take place based on how people are responding to the initial intervention. And so on the SMART, there's a series of kind of multiple randomizations. People get randomized multiple times to various treatment conditions to then at the end of this come to, well, when a participant said, let's say, has obesity, um, you're going to start them with this standard behavioral lifestyle intervention. And if they respond to that, you will continue with that behavioral lifestyle intervention, in this case here. Or if they are not responding to this intensive behavioral lifestyle intervention, you're going to randomize them to get intensive behavioral treatment with meal replacements, or you're going to switch them to a totally different intervention, such as acceptance and commitment therapy. Um, and in this particular smart design right here, what they're doing is they're not only testing out what is the appropriate intervention to move people to adapt people to, but the initial intervention, should it be 5 weeks or 10 weeks, and then it proceeds on from there. With the multi-phase optimization treatment strategy, or MOST, what you're really trying to do is make sense of the kitchen sink that we usually do for our for our interventions, particularly especially our behavioral interventions. We usually just throw the book at people and say we're going to try this component and this component and this component, and hopefully all of these things combined, there's going to be some sort of significant effect, and there usually is. But then, right, those interventions tend to cost a lot of money, and so the implementation of those interventions in the real world are less likely because they are too costly and too resource intensive and time intensive. Um, so what most is about, and I'm totally simplifying this, is about kind of taking the various components of an intervention and really trying to figure out what are the components that we really need, and what are the components that that are probably not really that effective or not really part of that key ingredient. And and figuring out which one of those components or set of components that we need, how can we optimize and deliver a behavioral intervention that costs, let's say, $500 per person. And so all of that kind of goes into this most design in terms of figuring out, and usually they are factorial design. So you will say component A versus component A plus B versus component C, etc. Again, I'm totally simplifying this and happy to share some additional papers on this if folks are interested in learning more about this approach. But in both of these instances, the idea is that with the SMART is that you will come out with an adaptive intervention that then you will test out in an efficacy trial compared to, let's say, usual care or some sort of control condition. And similarly, with the most design, you're going to come out with an optimized, you know, just having the key ingredients, just having those key effective components, preferably low cost, that then you can also test out compared to a some sort of control condition. So with the orbit model, that really takes you through kind of the traditional intervention design phase. You start with, you know, your clinical research question, and then you move into kind of doing some proof of concepts and pilot testing, and then into the efficacy, and then into the effectiveness. That can take many, many years. And certainly if we're talking about really kind of brand new novel interventions, probably need to go through that process. But we also have interventions that are already kind of evidence-based, that we know are effective, or at least we have intervention components that we know are efficacious and effective. And so we want to kind of speed up that process of translation from research to clinical practice. And that's where these kind of hybrid designs come in at. And so that's other paper by Karan and others really kind of gives a nice overview of these hybrid effectiveness implementation trials. And so just to reiterate kind of some of the definitions in that manuscript, the hybrid type 1 trials involve testing a clinical intervention while gathering information on its potential for implementation in the real world. So you're basically doing an effectiveness trial, but you're also collecting data, which also often involves doing qualitative interviews to understand what are the barriers and facilitators to implementing that intervention, let's say in a health system or the school system or in the community-based settings. And so you're not really doing anything to force the implementation, but you're really just trying to understand what's going to be needed to improve implementation later on. And the hybrid type 2, you are simultaneously testing the effectiveness of the clinical intervention and the implementation of it. So you know, you have your behavioral intervention or your clinical intervention that you're trying to test, is it effective for a given outcome? But then you're also testing a series of implementation strategies. So how are you getting, let's say, providers or school or teachers or community-based organizations to implement, uptake your particular clinical intervention. And implementation strategies, examples of those include having an advisory board or doing what they call audit and providing feedback. So you're kind of auditing the performance, let's say, of clinicians. So you're auditing whether or not they are doing blood pressure screenings or measuring BMI, and then you're providing that feedback to them in terms of how many patients in a given time period they actually followed through on that quality metric, let's say. Other examples of implementation strategies include a train-the-trainer model. So, you know, you have study staff go and train someone, and then that trainer then goes out and trains people in the community. That's a way to kind of not only implement, but also to potentially scale up or sustain your intervention. Another example is practice facilitation. So sending experts in to help train and facilitate practice reorganization or reform right there on the ground based on what they have already in place. And then the hybrid type 3 is testing and implementation intervention strategy. So some of those examples that I just gave in terms of intervention strategies, implementation strategies, while you are observing and gathering information on the clinical intervention and related outcomes. So with the type 3, you're really just more so focused on the implementation of the intervention. But you're just kind of following in the background, making sure that your intervention is still performing as you expect it to perform. You still want your intervention to be effective, but you're not so much testing the effectiveness of the intervention, you're testing the implementation of it. Can you get it to 3 or 4 different sites, and can you get it implemented into 3 or 4 different sites for a year or 2 years or however long you want that intervention to take place? And the third article that I shared by Friedland and all, I'm not going to go into that one in detail, but the reason, because it's more about study design, that particular article, but I just wanted to highlight that, when you're thinking about, when you get to the point of the phase 3, the efficacy trials, even before that with the pilot testing, whenever you're thinking about kind of a comparator arm, it's important to choose the right comparator arm, not only to understand whether or not your intervention works or not, but the comparator arm also helps you to start to think about, again, what additional refinements need to happen to your intervention. And so if your comparator arm, let's say, is usual care, and your intervention doesn't outperform usual care, what are some of the intervention components that might be dragging down your intervention, that might be burdensome to the participants? And so therefore they're not engaging. They rather have usual care than your intervention. If your comparator arm is attention control, and so you're having the same level of attention, um, um, but your intervention is not better than attention control, again, what can be refined there? Should it be more of a technology-based intervention? Should there be even more sessions than the attention control, et cetera? But I just wanted to point out that even when you get to the point of starting to test your intervention, again, that development and that refinement is iterative. It's an iterative process, and you can learn a lot by what you choose to compare your intervention to. So intervention design basics, just some questions to ask yourself. The very first question I think you should ask yourself is, what is your research question? And that goes back to the orbit model, is what is the significant clinical problem or the significant clinical question that needs to be answered? If you can't say that research question or come up with a research question in a sentence, not a sentence because it's a question, sorry. um, then you're kind of going to be all over the place in terms of your intervention, and your intervention's not going to have really focused direction. And so they're having that research question and really being able to state what the problem is and what you're designing the intervention to do will help to really kind of narrow the focus and make sure that your intervention is streamlined and it makes sense. Additionally, you want to think about, what is your target population? So if you're working with kids, right, does your intervention perhaps probably need to be less didactic and more interactive? Do you need to involve parents if you're going to be, even though your target population is kids? If you're working with older adults, does it make sense to have a technology-based intervention? Is that going to be feasible for them? If you're working with Latinos, does your intervention need to be delivered in both English and Spanish? And by delivering in a different language, does that change some of the components of the intervention, or really the effectiveness of the intervention, because it's delivered in a different language? So all of those things to think about in the context of what your target population is. You want to make sure that your intervention is tailored to that population, and that it's going to be feasible for them to engage in it, and that they're actually going to be able to uptake the intervention. And then, what is your primary outcome? So I think that's certainly very important in terms of kind of where are you starting from? What is the outcome that you're trying to change with your intervention? And are there any secondary or intermediate outcomes? So the intervention design that I'm going to go over is our disparities elimination through coordinated interventions that promote health through empowerment and resources in the Pacific Northwest. I'm just going to refer to that as Decipher Northwest because I realize that is a very long title. And so the research question for Decipher Northwest was, does a combination of implementation strategies at the clinic, provider, and patient levels enhance the uptake and sustainability of evidence-based interventions for blood pressure control among patients of color, low-income patients with uncontrolled blood pressure? So really just, what are the implementation strategies? Or does a certain combination of implementation strategies enhance the uptake of interventions that we know that work for blood pressure control in this target population of patients of color and low-income patients? And to develop this intervention, we actually did quite a bit of stakeholder engagement up front. And that was because, again, we want the intervention to be sustained in the community and the clinical practices that we will be working with. So we, in the very beginning, engaged community-based organization representatives, health system leaders, clinicians, payers, other subject matter experts to help us think about what are the outcomes, and what are the intervention components, and what are the implementation strategies that we should be thinking about. So for Decipher, as I said before, you want to think about what your outcomes are going to be. And then for me, I kind of work backwards from there. So I think for some of you all, I've talked about kind of having this path model in mind when you're thinking about your intervention design. And so for Decipher, our primary outcome, of course, is blood pressure control. We wanted 85% of our patients enrolled to have controlled blood pressure. And then secondary outcomes included reduced healthcare costs and enhance health-related quality of life. So starting with those particular outcomes, then I had to work backwards, or we had to work backwards and think about, well, what are there intermediate outcomes that will then lead to these primary and secondary outcomes? And then what are the interventions, implementation strategies that need to happen in order to then move these outcomes of interest? So in addition to designing the intervention, we very early on decided on what our target population would be, because again, that's going to inform the intervention. So this is a clinic randomized intervention or study. And so we were particularly looking at primary care clinics in Oregon with 50 or more patients with uncontrolled hypertension. And then within those clinics, the patients who were eligible to participate were patients of color, so non-white, but they could be white participants if they were low income or had Medicaid. And then they also had to have uncontrolled blood pressure, and they were receiving ongoing primary care at one of the eligible primary care clinics. So with that in mind, so we have kind of a mixed bag of our patient population. We have patients of color, we have some low-income white patients. We also allowed for patients who spoke Spanish or patients who were bilingual. And so that means that our intervention needed to certainly have materials that were at appropriate literacy level, low literacy level, and also that were available in English and Spanish in terms of our educational materials, and that we also had interventionists that were bilingual and that were representatives of this patient population that we were trying to recruit. So intermediate outcomes. We particularly look at medication adherence, weight loss, and increased psychological empowerment. And we looked at those intermediate outcomes, one, because we know that with medication adherence and weight loss, the literature, there's tons of studies that show that those two things are important in terms of blood pressure control. And then the increased psychological empowerment, that actually came from our community partners who said, and I'll get into this in a few minutes, and that this is also a community health worker-led intervention, at least the patient part of it is. And so we know that with community health workers, there is the end result of that not only is behavior change and improve disease outcomes, but also there is increased empowerment amongst the participants. And we believe that with this increased psychological empowerment, that would lead to this enhanced quality of life. So then to get into what exactly our interventions were. So I have up here, I know evidence-based innovations. You can replace the word innovations with interventions, but the first thing was, there are national blood pressure guidelines that are out there right now. I think the latest one was in 2017. Um, and the idea is that all clinics and providers will follow these guidelines. And so part of the intervention was to make sure that providers had access to these guidelines, which did really focus on repeated measurement of blood pressure, following a certain algorithm in terms of the medications, etc. And so we wanted to make sure that providers had access to these guidelines and that they were implementing these guidelines, because we know that adherence to these guidelines leads to medication adherence and overall blood pressure control and reduced healthcare cost. We also looked at other evidence-based interventions such as the DASH diet, home blood pressure monitoring, behavioral lifestyle interventions, as well as navigation to resources. And what I mean by that is that because we're also working with patients who are low income, we wanted to be aware of any socioeconomic needs that they may have. So as we're talking to people about following the DASH diet, they may not have money to get fruits and vegetables. So we wanted to help them to navigate to get resources and access to fruits and vegetables and other healthy foods. Um, Part of the blood pressure guidelines is to go in and get your blood pressure rechecked. Well, if people don't have regular transportation, we wanted to also provide resources either for people to take an Uber or to get on the bus to make sure that they can make it to their medical appointments. So all of that was part of the evidence-based interventions that then led to these intermediate outcomes that then led to these primary secondary outcomes. And then the implementation strategies that we use, which I talked about a little bit earlier, just to give some examples. But the way in which we try to make sure these interventions were getting implemented is that we, at the clinic level, we provided feedback to the providers in terms of whether or not they were actually screening for blood pressure, rechecking blood pressure, following the guidelines in terms of adjusting medications as needed. So we're going to supply them with that type of feedback and data. We also are going to have practice facilitators go into the clinic to see what's happening on the ground and provide support to nurses, medical assistants, as well as the physicians, and being able to better adhere to the blood pressure guidelines. And then we were going to embed a community health worker within the care team. And so with the embedded community health worker, one, they are kind of the liaison between the patient and the care team, but also between the community and the care team. CHWs can really help to set the context for what's going on in the real world of the patient when they leave the doctor's office, and why there might be barriers to them managing their blood pressure, so that the care team is aware of that and can make adjustments in terms of the treatment plan, to ensure that the treatment plan is optimized, but also tailored for a given patient. At the provider level, we were going to provide provider education, again, related to the blood pressure guidelines, but then also how to work with diverse patient populations. And then electronic health record-based tools. So tools that provide kind of clinical reminders to screen for blood pressure, high blood pressure, to recheck medications, to follow up with patients. Those are tools that were already embedded in electronic health record that we were just going to emphasize for providers to use. And so across these two levels, the clinic and the provider level, with these implementation strategies, we hypothesize that adherence to the guidelines would increase, therefore improve medication adherence, and again, overall improve blood pressure control. And then lastly, at the patient level, as I said before, the community health workers would then be conducting home or phone visits with the patients to implement the behavioral lifestyle interventions, particularly focused on the DASH diet and home blood pressure monitoring, and also to provide navigation to community-based resources to address any socioeconomic needs. But the implementation strategies, which really were more sustainability strategies, were to implement a CHW train the trainer. So the study staff would train the CHWs in delivering these interventions, but then we would have CHWs go on to train other CHWs, so that this intervention can last beyond the research study itself. And then finally, we also had ongoing supervision with the CHWs to ensure that there was treatment fidelity, and that the CHWs had support to deliver these interventions that then led to this weight loss, increased psychological empowerment, improved medication adherence, and again, these primary and secondary outcomes. So the comparison arm for Decipher actually was waitlist control clinics, which means that, after about a year, clinics that were randomized to the control arm would then receive the intervention. So they just had to wait they were going to have to wait for about a year. Um, and patients within the control clinics did receive educational materials for blood pressure management. And then we're also kind of tracking what is a standard practice or usual care practice in each of the control clinics via qualitative interviews to understand really what does blood pressure control look like in terms of usual care. So I should point out that Decipher Northwest, it hasn't quite started up yet. So I think I move between tenses and talking in both past and future tense. But so if anyone is interested in what are the results, there are no results yet because it hasn't been started yet. But those are certainly our plans for the Decipher Northwest. But in terms of key lessons learned that I've learned over time, and certainly with just developing Decipher, the Decipher intervention, is it really helps to map out the intervention pathways to make sure that you're getting all the intervention components in there that need to be there to act upon the various primary, secondary, intermediate outcomes. And I really recommend creating a visual, really kind of laying out a visual picture of what your intervention is doing and what it is acting upon. And then lastly, although it takes quite a bit of time, and it really depends on what stage of the intervention development that you're in, is to really think about engaging stakeholders. If you're really at a point of you're just trying to implement something that you already know is evidence-based, you already know it's efficacious, and you just want to implement it, really engage those stakeholders and think about how do we do this? How do we do this on the ground? How do we do this in the real world? If you're at the pilot phase, certainly if you have time or you have funding, it doesn't hurt to also engage stakeholders at that point to really refine the intervention at that point as well. But again, just keeping in mind the time that it may take. And here is just my email address. Certainly, I am always open to please follow up with me if you have any additional questions or you want to run by some of your ideas or thoughts about an intervention that you're planning to develop or planning to test out. I'm always happy to answer any questions and talk that through. And I look forward to seeing you all on October 27th and having a good discussion. Take care.